Hi, this is Dr. Bernstein with your December 2017 teleseminar. As usual, I want to remind you that my answers to the questions that are presented are theoretical. They're not going to be necessarily applicable to the questioner, but are of general interest. Reason is I cannot take a physical examination on every questioner. I can't get a complete history. They might not even specify what medications they're taking. So my answers are guesses, but they're meant to educate the readers, the listeners in general. For a special subject today, we're going to talk about preserving C-peptide production. The reason I've brought up this subject is because we get many questions from listeners. How can I preserve my C-peptide level? Now, what is C-peptide level? The precursor of insulin is a molecule called proinsulin. And proinsulin has an extra short chain of amino acids attached to it that gets clipped off when it gets converted to insulin. And this short chain is C-shaped on the proinsulin molecule. So it's called C-peptide. Now, for every insulin molecule that the body makes, it has to therefore make one C-peptide molecule. And it's more reliable to measure a person's C-peptide level than their insulin level, because if you're trying to look at endogenous insulin, the insulin that a patient made, he could be injecting insulin, raising his blood insulin level, and totally confusing the insulin level, a mixture of injected plus his own. But if you look at C-peptide, you'll just get a measure of his own insulin production. So you can't deceive the C-peptide level. By the way, most physicians specify a fasting C-peptide level. I always prefer a post-meal C-peptide level with the blood sugar at the same time, because if a non-diabetic happens to have a low blood sugar, or even a diabetic, they're not going to be making much insulin. Their C-peptide will be low. And if you eat a meal and raise your blood sugar, the C-peptide should go up. And if you have a high blood sugar and a low C-peptide, you know this person is diabetic. Anyway, we'll get on to the importance of C-peptide over and above being an indicator that you're making insulin. There's an article in the 2004 issue of the journal Diabetes Care that lists some of the functions of C-peptide by itself. In other words, when insulin is made, C-peptide is made, and the C-peptide does a lot of things that are important. And I'll quote, "In patients and animal models, C-peptide corrects glomerular hyperfiltration at the onset of diabetes." That means overaction of the kidneys, reduces albuminuria, albumin in the urine, decreases mesangial matrix expansion. That's a part of the kidney that enlarges in diabetics and compresses capillaries in the kidneys. C-peptide also normalizes nerve conduction velocity in the early phase of diabetic neuropathy and ameliorates or reverses diabetes-induced nerve structural changes. C-peptide administration, which is done, I guess, in animals, increases blood flow in peripheral nerve, kidney, skeletal muscle, myocardium, that's the cardiac muscle, and skin. accelerates myocardial repolarization, increases ventricular contraction and relaxation velocities, improves stroke volume, improves red cell deformability, and increases muscle glucose uptake. So there are many, there's much value to C-peptide production aside from the fact that it indicates that you're making insulin. Now, as I've said over and over, one of the best ways of preserving insulin production in early diabetics is normal blood sugars, because high glucose is toxic to beta cells that make insulin. But there was another article in Diabetes Care in the year 2013 that demonstrated that fish oil or omega-3 fatty acids can improve C-peptide, can preserve C-peptide in youth with recently diagnosed type 1 diabetes. So I assume that this would also apply to adults with recently diagnosed type 2 diabetes or type 1. So they don't make a recommendation as to how much omega-3 fatty acids you should take, but if you eat oily fish on a regular basis, if this study is correct, it should help preserve the C-peptide. Will it be as effective as keeping blood sugars normal? My guess is no, that you have to do both, and that the most important thing is to have normal blood sugars. Now we'll get on to our questions. A month ago, diagnosed 29-year-old type 1 diabetic, blood sugars running between 4 and 5.6 millimoles, which would be 72 to 100 milligrams per deciliter. On Lantus injection in the morning and Novo Rapid for meals. I started to notice frequent drops in my blood sugar levels at early nighttime. I was instructed to stop using Lantus completely. Now my blood sugars are stable with only slight drops from activity. Should I be worried about not using basal having an adverse effect on holding to my honeymoon period? Well, this patient's doctor told him that probably that his blood sugars were too low, that he should stop using basal insulin. And I would say if all of your blood sugars are in the range of 75 to 80 milligrams per deciliter, you could stop the basal insulin. But otherwise, what I would recommend is that you consider switching to Tresiba and not using Novo Rapid for meals. Novo Rapid is the British equivalent of Novolog, which is too fast for a low-carb, high-protein diet for most of us. So most of us will do better using regular or crystalline insulin, and probably Tresiba as the basal insulin. But the important thing is that this person's blood sugars of 71 to 100 are a little on the high side, and one wonders what they are 1 hour and 2 hours after meals. You may need some regular insulin before meals. Type 2 diabetic, hospitalized with hyperglycemia high blood sugars and associated dehydration. I do not understand why they give 5% dextrose with a 9% sodium chloride to an already hyperglycemic diabetic. Well, this is a good question, and it certainly is inappropriate to give glucose to a diabetic with high blood sugars. However, this, I believe, is a hangover to the old days before we had blood sugar meters. When I was a kid, the labs were closed at night. They didn't have automatic machinery for the clinical laboratories. Everything was manual. The lab personnel went home at night, and the emergency rooms had no source of blood sugar determination. They could draw blood, but there was no laboratory to measure blood sugars. In those days, it took about an hour to do the testing. You had to boil the serum in a solution for an hour or so. It was a complicated process. So what they would do is and they couldn't tell the difference between an unconscious diabetic and an unconscious drunk. And they got equal numbers of both. So how do you tell the difference? Or how do you treat them? Well, you assume that they're both drunk and they're both hypoglycemic, because hypoglycemia in diabetics was much more frequent than hyperglycemia. So, and they could test the urine for glucose, but if there was no glucose in the urine, they didn't know that this person was a diabetic. So they would give everybody glucose, assuming they were diabetics with hypoglycemia, and they'd give everyone thiamine, which is what they used to give to drunks. So if you went in the hospital with hypoglycemia, you'd get glucose and thiamine. If you were drunk, you'd get glucose and thiamine. And at least with the glucose end of it, they never changed it. And it's shameful. There are a few hospitals where people are being treated properly. And there may be certain departments in hospitals. For example, if a diabetic goes into a hospital in kidney failure and they have a dialysis center, it's likely that the people in the dialysis center will give them straight saline for hydration and not give them glucose. I am on insulin and cannot lose an ounce. I eat low carb, recently had an A1C of 6.6. What can I do? Well, first of all, read my book, Diabetes Solution. Secondly, this smells like polycystic ovarian syndrome, PCOS. So I would guess that this person is female. And I've commented over the years that people with PCOS can eat nothing but air and not lose weight and even gain weight. It's amazing how these people suffer with weight gain that's beyond their control. Now, I'm not certain that you have PCOS. Another possibility is that you are saying that you're on a low carbohydrate diet, but it's not the low carbohydrate diet that we recommend. For example, you'll see on the internet many doctors and salespeople recommending low carb and pushing whole grains, fruits, and other high carb foods. So it could be that that you should read my books and use the kind of low carb diet that we advocate. I'm a type 1 very brittle diabetic. Now, when I hear the term very brittle, I right away challenge it because aside from gastroparesis or infections, most type 1 diabetics are called brittle, but it's the treatment that's brittle. I was a very brittle diabetic until I cut the carbo and started taking multiple insulin shots and small doses of insulin rather than the industrial doses that my physicians were giving me. So back to the question. Very brittle diabetic since I was 12 years old. I'm now 47. So this person is a survivor. A1C is currently 8.1. What should I do? Well, 8.1 is an average blood sugar of about 220 milligrams per deciliter. And I might point out, don't use the ADA's translation of A1Cs to blood sugar. It's not correct. Anyway, read my book. It tells you how to normalize your blood sugars. You're probably going to have to go to a very low carbohydrate diet. By now, with all these years of diabetes, you probably have gastroparesis. So, there's a chapter in the book on treating gastroparesis and so on. So read the book. Does cooking the vegetables turn their slow-acting carbs into fast-acting? It can. Depends how long. If you cook the vegetables just long enough to warm them up, it shouldn't make a difference. But if you cook for hours, you're going to break bonds between glucose molecules. And fiber, vegetables are high in fiber. Fiber is polymers of glucose molecules, chains of hundreds or thousands of glucose molecules, and they're broken apart by heat. So the longer you cook them, the more likely you're going to turn fiber into rapid-acting carbohydrate. Does it matter whether I eat high protein versus high fat as long as I eat low carb? I read that excess protein turns into glucose, but not excess fat. That makes me wonder whether I should eat more fat. Again, read my book. And what I do is I eat the fat that comes with the protein. So I'll eat cheese and eggs and fish and bacon, and whatever the fat comes with the protein is what I eat. There are too many people out there who are putting themselves on what they call high-fat, low-carb diets and not getting enough protein. And I've seen these people, and they come in very sickly with a lot of abnormalities in their blood tests. And I do not at all recommend cutting out protein or cutting back on protein and substituting fat. What is the relationship of insulin resistance to type 2 diabetes? Well, one can say it's statistical in that many people who are called type 2 diabetics, I'd say the majority of them, are overweight and are therefore insulin resistant. There are some people called type 2 diabetics who are slim, and may not be insulin resistant. There are also type 1 diabetics who are obese and would be both type 1 and insulin resistant. So it happens that as abdominal fat increases, and we're really talking about peritoneal fat, that lines the intestines, covers the outside of the intestines, that tends to cause insulin resistance. Um, White fat as opposed to brown fat in the abdominal area causes insulin resistance. High muscle mass lowers insulin resistance. So it's a complicated sort of thing. And I guess the best answer is that it's a statistical association with type 2 diabetes. Most type 2s are insulin resistant. Feeling lightheaded if I go too long without food. Am I not eating enough fats? Sounds like the same person, maybe. Well, it depends what medications you're taking. You should certainly check your blood sugar when you're lightheaded. If you're not diabetic and not taking medications, you might have reactive hypoglycemia, which affects a lot of people. In fact, it's a precursor frequently to type 2 diabetes. I certainly would not advocate eating fats to treat reactive hypoglycemia, and it's not likely to make you feel better from feeling lightheaded. It's not that I'm against fats. I have a high LP. No, I'm going to skip this one because it requires a half-hour answer. What do you think of this fasting diet study? Can we really reverse even type 1 diabetes, and can the beta cells regenerate? And several internet sites are cited. And I just have to warn you that there's no magic to treat diabetes. There are several different fasting regimens by people who are usually selling something to go with it, either a book, videos, food, pills. I've had patients come in here who had been fasting alternate weeks, fasting alternate days, fasting 2 or 3 days a week. And what happens as a rule is that most of them were overweight and they lose weight and then regain the fat, but not the protein. So not the muscle. So you regain fat much more rapidly than you do muscle mass. And starving yourself depletes both fat and muscle, but it's much easier to replace the fat. And these people tend to get hungry. They sometimes overeat in response to their prior fast. So I don't recommend this, and there's no cure for diabetes that I know of. I've seen many claims. There are some countries that offer more cures than other countries, interestingly enough. People on our type 1 grid page are talking about gaining weight from Tresiba. Do you know if there's any legitimate concern for that or of studies done? I've not seen any studies of weight gain from Tresiba. There is the possibility that people may be getting more insulin than they need. And if your basal insulin is too high, it's going to force you to eat and you could gain weight. I have many people on Tresiba. I just, before we started recording this teleseminar, I spoke to a patient of mine out west who's lost about 15 pounds in the past few weeks. She's taking Tresiba. I haven't seen a problem. My guess is if people are experiencing weight gain, that they're getting too much. Remember that most diabetics are getting too much basal insulin. Sometimes they're getting twice as much as they really need. What prognosis do you foresee for pre-diabetics who can keep A1C blood sugars under 5 with 80 grams of carbs per day? Well, I guess this is a person who's eating 80 grams of carbs per day and is keeping his or her A1C under 5. One wonders how much protein are they getting? Are they depriving themselves of protein? Is their muscle mass going down? There's so many questions. My guess is that it's harder to have steady blood sugars when you're eating a lot of carbohydrates. And this is about 3 times as much as I recommend for the average adult. It would be interesting to know what sort of, it's one thing to have an A1C under 5. I doubt that this person has it. I think they would like to have it. But it's also a matter of having blood sugars level. I've been a type 1 diabetic for 25 years. My last 2 A1Cs were 5.6 and 6.1. 6.1 is about an average blood sugar of 144 milligrams per deciliter. So I consider myself to be in good control. Over the past 2 weeks, I've been feeling hypoglycemic symptoms near constantly. My meter blood sugar readings are within the normal range, or even elevated to 170 after a meal. I am not sure where to go from here. I feel like I'm going to pass out at any moment. Well, could be a lot of things. It could be that you're so used to high blood sugars that when you come down to normal blood sugars or near normal blood sugars, you feel hypoglycemic. That's very common. So that's one possibility. Another possibility is postural hypotension, which is associated with autonomic neuropathy. If you've had diabetes for 25 years and most of the time your blood sugars were elevated, you probably have autonomic neuropathy. And what we find in such people is if you check their blood pressure when they're supine and then have them stand up after lying down for a few minutes, their blood pressure drops and they feel like they're going to pass out. So autonomic neuropathy can cause postural hypotension, which can give the symptoms that you're experiencing. I can't think of any other causes. You might want to read my book, Diabetes Solution. And by the way, I don't get huge royalties from it. Late onset type 1, A1C 6.5. That's an average of about 160 milligrams per deciliter blood sugar. Levemir, 8 units at bedtime and 4 units in the morning. Not using bolus yet, so it's not covering his meals with insulin. Please explain how come I get hypo sporadically, only being on basal insulin, upon waking and after intense cycling. Well, first of all, this person is getting twice as much Levemir at bedtime than in the morning. So he may be getting more insulin than he needs. And this can cause the hypoglycemia in the morning. After intense cycling, anyone with diabetes who's on a fixed dose of insulin can get hypoglycemia. So it's not a mystery. I might also point out that if you were doing the cycling in the morning, chances are your blood sugar might go up. But you call yourself a late onset type 1, but I suspect that you're very mild type 1 if you're getting away with only 12 units of insulin a day. Although your blood sugars are on the high side, they're not at the astronomical levels that we usually see with type 1s getting that little small amount of insulin. But take a look at my book, Diabetes Solution. If you have a type 1 toddler with loss of appetite from illness who isn't eating, but their blood sugars are in range, they're taking basal insulin but not bolus, they're well hydrated, are ketones a concern? At what level would you worry about ketones? I think that you should start looking at blood sugars rather than ketones. Unless you have very high blood sugars, let's say in a little kid over 200, you're not going to have ketoacidosis. You can have starvation ketosis in anyone, not just diabetics, and that's not usually harmful. Probably not ever harmful. So I would say you should read my book and focus on blood sugars, not ketones. My health insurance company is making me switch from Levemir to Lantus next year. After 5 years on Levemir, I'm a type 2. Anything I need to watch for after making the change? Is more weight gain possibility with Lantus? Differences in effectiveness or the way it performs? I haven't read of any significant differences in their effectiveness or the way they perform. I'm not satisfied that the threat of elevated cancer risk with Lantus does not exist. I think there's enough evidence to be concerned about that. But that's my only objection to the Lantus. I might point out that both Levemir and Lantus may not last long enough for all type 1 diabetics. I find Tresiba lasts longer and is therefore preferable for many of us. What's happening in my body that causes terrible cramping when my blood glucose is too high? Well, this person doesn't say where the cramping is. Is the cramping abdominal cramping? Is it nocturnal leg cramps? If it's abdominal cramping and you have gastroparesis, we do know that the neuropathies get worse when blood sugars are elevated. And people have told me that even in a matter of hours, if they have numbness or pain in their feet, it gets worse when their blood sugars are higher. So it could cause pylorospasm, spasm of the pyloric sphincter at the bottom of the stomach. That's common in gastroparesis. Rarely do I see, I don't think I've ever seen patients with gastroparesis who had pain in their abdomen. But I could see in theory that if you have severe enough gastroparesis and your blood sugars are very high, maybe you get pylorospasm, and that could be painful. I just started weight training. I take a reading before I go, and it is between 72 and 100. After working out for under a half hour, my reading can be between 250 and 300. I eat after I work out. Well, if the person is measuring his or her blood sugar after eating, it could be from the food that the blood sugar goes up. If the blood sugar goes up, I find it hard to believe that weight training would raise your blood sugar, except if it's in the early morning. If it's during the time of the dawn phenomenon, first, let's say, 4 or 5 hours in the morning, many people have blood sugars that go up from any kind of exercise, and the more strenuous the exercise, the higher they seem to go. But if it's in the afternoon and your blood sugar is going up, it's sort of hard to believe. It could be that you should be on insulin. I don't know. A type 1 diabetic who's not getting enough basal insulin might go up after exercise at any time of the day. So there's not enough history here to really figure out what's going on. Type 1 female for 24 years. A1C since diagnosis never really has reflected blood glucose levels, and it has always been lower than expected, judging from blood sugars, currently at 4.4%, with average blood sugar on the meter 131. Fructosamine, that's another way of measuring average blood sugar. It's a 2-week moving average. Fructosamine is more reliable and when converted shows a significant discrepancy from A1C. What could be the cause of such a low A1C? Well, one problem could be using the ADA's formula for converting A1C to blood sugar, which is grossly inaccurate. If you look at the formula that's in my book, it was born of an accurate study that was performed a number of years ago. So use the formula in my book. The other thing is you may have an inaccurate blood sugar meter. So use the meter that we recommend, which currently is the Freestyle Freedom or Freedom Light. The last possibility would be if you have some condition that causes slow turnover of red blood cells. If they turn over very slowly, the hemoglobin is going to be more glycosylated and you'll have a higher A1C value. So you could see a local doctor and ask him to check you for a variety of anemias, probably macrocytic anemia, that might artificially cause elevated A1Cs. I'm a type 2 diabetic on metformin and gliclazide, morning and evening. Gliclazide is sulfonylurea. No matter what time I take the evening dose, I wake up with a high of 11 millimoles, which is about 200 milligrams per deciliter, which I presume is the dawn phenomenon. What would you advise? I next ask my GP to help me improve. Oh, what would you advise? I asked my GP to help me improve my blood sugar reading. First of all, I'd say you read my book so that you could really understand these things. Diabetes Solution. Now, it could be that your morning blood sugar goes up if your bedtime is shortly after dinner, you might have a high blood sugar from dinner that if you have gastroparesis, you won't see it because your stomach emptying is delayed and you're emptying while you're asleep. It could be high the next morning. You may need insulin to cover your meals, or you may need basal insulin for the overnight. And we always recommend that people not take sulfonylureas for at least two reasons. One is that they burn out beta cells, or we could say that they impair the activity of beta cells. And the other is that they've been associated with cardiovascular disease. So you might be better off with insulin than the glycoside. Or it could be that you could use metformin or a variety of other medications. But read the book so that you get a better picture of the treatment of diabetes, better understanding. Next one. We use fortified powder milk for school-age children. This makes her blood spike. What should we do? Is there a low-carb substitute for milk with the same nutritive value? Well, first of all, I suggest you take a look at Facebook, take a look at type 1 ONE GRIT, G-R-I-T, and you can see what other parents are doing for their type 1 diabetic children. I recommend heavy cream. Heavy cream tastes better than milk, and it's got much less carbohydrate in it. The powdered milk is in effect fortified with sugar. You certainly shouldn't use powdered milk. So heavy cream is the answer. You can add flavoring to it, like there are some sugar-free chocolate syrups. Don't remember the brands offhand. There's also Da Vinci's cookie dough syrup, which a lot of kids like in their heavy cream. And you don't have to bomb kids with milk. They don't need a lot of milk. What is happening in my body that causes sweating, etc., when my blood glucose is too low? That's the production of epinephrine, adrenaline. Your body is properly responding to a low blood sugar by making epinephrine. Epinephrine will raise your blood sugar, and in fact, there is some discussion nowadays of using epinephrine to treat severe hypoglycemia instead of glucagon because it's so much less expensive than glucagon. It also is available in EpiPens. It's sold as a liquid, not as a powder, so it doesn't have to be diluted. It doesn't take an effort of mixing with diluting fluid and so on that the glucagon requires. Also does not cause the nausea that glucagon can cause. So if your body's properly making epinephrine, that's great. There's a possibility if you had lots of hypos that eventually your cells don't respond to the epinephrine. But the fact that you're getting the sweating shows that you are getting a response. It also dilates the eyes, causes tremors, and a few other symptoms. I've had a hard time keeping blood sugars stable after a meal. If I take a half unit of regular insulin with my 12-gram carb meal and wait 30 to 40 minutes to start eating, my blood sugar will be 1 to 2 millimoles, that's 18 to 36 milligrams per deciliter, higher after my meal. It does come back down after about 3 hours by itself. If I take 1 unit of regular, my blood sugar will stay stable for 2 hours and then will go too low subsequently. Well, first of all, read my book, Diabetes Solution, and you might experiment not with the dosage, but with the timing before the meal. For example, if you do not have gastroparesis, you may need 40 or 50, 45 or 50 minutes before a meal rather than 30 to 40 minutes. So that would be the first experiment that I would make. But also read the book because it'll, again, make the problem easier to handle. Do ACE inhibitors and similar blood pressure meds actually protect against kidney deterioration in diabetics? Yes, but not everything protects the kidneys. The ACE inhibitors do, but not the ARBs, the angiotensin receptor blockers. They have not been found to preserve kidney function. I am an orthopedic surgeon and a type 3 diabetic. Just curious about some reference or bibliography about the Chinese restaurant effect that I find completely true. I have looked for the cascade description unsuccessfully. And here he gives a number of Chinese words. He's looking in Chinese journals to read about this. The technical name for this, which, by the way, was created long after I coined the term Chinese restaurant effect. I coined the term in the 60s, I'm sorry, in the early 70s, and the incretin effect was coined, I believe, in the 80s. The incretin effect is an effect where if a diabetic is given oral glucose, it will raise his blood sugar more than if he's given intravenous glucose. And so look up the incretin effect. You won't find Chinese restaurant effect in the literature unless I've written it. Please could you explain about Afrezza insulin and whether you recommend it for a type 1. Afrezza is an inhaled insulin. I don't know if it's still on the market. The big problem with Afrezza is you cannot control the amount that's absorbed. Every dose will be absorbed differently. It's sprayed into the nose and inhaled, and as you could well imagine, you could on one installation absorb 10 times as much as you would on another installation. It depends how handy you are with the puffer. So if you want to have uncertain blood sugars, you'd use the Afrezza insulin. Now, it might be of some value for type 2s who are insulin resistant, may want to eat a meal where they would ordinarily not cover it with anything, and they find that a puff of the Afrezza might prevent a blood sugar increase today by 10%, tomorrow by 50%. At least it's preventing some degree of the increase. Even though it varies each time, it's better than nothing. But the alternate would be to eat a low carbohydrate diet and get predictability. I'm an 81-year-old male type 2. I have recently been diagnosed with giant cell arteritis and lost vision in my right eye. Treatment is 50 milligrams of prednisone a day, and that has pushed my normally well-controlled glucose levels into the 300s. I just started Humalog insulin to combat this. Any advice on how to best counteract the prednisone? The prednisone tends to work all day long, but it also has a peak during the first few hours after you take it. So you may need not Humalog, but regular insulin. Humalog is too fast because the prednisone starts up slowly. You may need regular insulin at the time of the prednisone dose. And you may also need Tresiba insulin once or twice a day to cover the whole day of basal insulin. Is there any dessert other than sugar, a sugar-free Jell-O, that could be acceptable? Yeah, if you read my book, Diabetes Diet, this was written by the mother of a type 1 diabetic boy. She owns a gourmet restaurant and is a gourmet chef herself. And she made maybe 100 or more different recipes that are in this book, including many desserts that are low in carbohydrates. So take a look at the book Diabetes Diet. You'll also probably find some desserts in my book Diabetes Solution. I read there is current evidence linking the gut microbiota with autoimmune disease, specifically type 1 diabetes. Do you think there's any truth in this? Yeah, I think that there's been a lot of literature associating autoimmune disorders with the microbiota, but there's not specific guidelines on whether you should do anything. I've seen people taking all kinds of probiotics, thinking that by somehow increasing their microbiota, they're going to change things. And each person has evolved their own microbiota, that is, what bacteria are living in your gut. And to tamper with that could be asking for trouble. And that's why I recommend probiotics when you're taking an antibiotic, because the antibiotic is going to destroy your microbiota, and you want to replace them. So we take probiotics under those conditions, but not in an arbitrary or a random fashion where we don't know what we're doing with the microbiota. What do you think about the Medtronic MiniMed 670G insulin pump? I think that insulin pumps should not be used for diabetics. I've never seen a person with well-controlled blood sugars who was on an insulin pump long term. I did have one patient who came to me poorly controlled. We put him on a low carbohydrate diet and allowed him to, he insisted on keeping his insulin pump. He was psychologically attached to it. And since we were able to control his blood sugars, things went all right for a year. But after about a year, the blood sugar started going haywire as inflammation and scar tissue started to develop at the pump sites, at the insertion sites. And that's unavoidable. I guess if you use pump insertion sites in your butt, you'd be able to find more sites and maybe not get as much scar tissue, but it would be pretty hard to do that because you'd never be able to sit down. So I say you stay away from all insulin pumps. By the way, the incidence of abscesses requiring surgical drainage average 1 per person per year. The incidence of ketoacidosis from pumps going bad at night where the needle comes out or there's a tubing blockage or something. I don't remember the statistics, but I believe it's something like once or twice per person per year on average. Next question. Is peanut butter okay? I'm referring to the kind that's 100% peanuts as the only ingredient. Well, that kind of peanut butter has 3 grams of carbohydrate per tablespoon. It's 18% carbohydrate by weight. So let's say that 1 gram, if you're an adult, not a child. If you're a child, you're going to be sky high. But let's say you're an adult and you have 10 tablespoons. And let's say that 1 gram raises you 6, so you're a fairly big adult. So you have 10 tablespoons, your blood sugar will go up by 60. It's certainly going to affect your blood sugar. And of course, if you eat 10 tablespoons, there's a good probability that you're going to want to eat another 20 tablespoons. So I'd say you stay away from it. I have added about 8 to 9 kilograms over a 4-month period rather than losing weight. That's about 20 pounds. Is this normal? I'm on a daily dose of 30 units of insulin per day. Well, this person is probably eating a lot of carbohydrate. And I would say you cut the carbo, you'll be able to cut the insulin, and insulin builds fat. But read the book, because you don't just do it arbitrarily, you have to do it in a scientific way. Can a low carbohydrate diet be harmful to someone with thalassemia major? Thalassemia major is an anemia that affects people from Mediterranean countries, and I'm certain that a low carbohydrate diet will not be harmful to them. How can I find a physician near me who follows the advice given in your book? We would be willing to drive some distance to see such a physician. Well, what I would suggest is that you ask your neighbors and friends if they know of a friendly family care physician. They tend to be willing to prescribe the things that we recommend in my book. Many of them actually read the book, and I've heard many people tell me that their family physician is giving my book away to his diabetic patients. So these physicians seem to be more willing than both internists and endocrinologists to help diabetics achieve normal blood sugars. What is your opinion about ketones in urine on a ketogenic diet? Well, they're not that helpful, but they're not necessary. And if you're diabetic, you don't want to focus on the ketones. You want to keep normal blood sugars. The ketones became popular when Dr. Atkins was advocating a weight loss diet, which was low carbohydrate. But when you're losing weight, you're metabolizing fat, and a byproduct of fat metabolism is ketones in the blood, which will show up in the urine. So it's evidence that you're losing weight, or I should say that you're burning fat. Now, if you're slim, you don't need that kind of evidence. So I would say you don't have to focus on ketones. Look at the scale rather than the ketones. I'm a type 1 for 7 years and on an insulin pump. I have your book and want to start your program. My question is, how do I know how much less insulin to give myself after going low carb? You have to read the book. It's in the book. And it's experimental. It's trial and error. You start low and you keep increasing it until your blood sugars are normal. And you're going to have to be varying both basal and mealtime insulin. And you're wise to have identical meals from one day to the next so that you can conduct experiments that are consistent. But it's all trial and error. You might get some help from the people on Type 1 O&E Grit in Facebook. Type 1, 10-year-old. Most recent A1C was 4.8. Doctor said too many lows in the 70s. Well, 70s are normal for kids. And that she will not be able to recognize her low symptoms, especially at night, and fears nighttime hypos. Doctors suggest reducing Lantus and going to bed above 100. Any thoughts about not feeling low symptoms when you have consistent normal or just below normal levels? Well, these levels are not below normal if they're in the 70s. An 11-year-old, no, type 1, 10-year-old kid, these are probably pretty normal. And if you have a continuous glucose monitor and you're going below 70, you'll catch them and hopefully and correct them promptly. We know that elevated blood sugars impair brain development in children and cause many other problems. There's every reason to avoid the high blood sugars, not go after them. You advise using glucophage and not generic metformin, as the latter is not as potent. Is it not good enough to simply take more metformin? Well, that's a very good question. It's not been tested. I have one patient who did that on his own and didn't suffer in any way. So I don't know what to say. I haven't, the fact that one person didn't suffer may not be strong enough evidence to tell other people to double a dose. There are potential side effects from metformin, such as impairment of vitamin B12 absorption. Now, it's in the literature, but I haven't seen it in my patients. So I don't know how frequent that is. But this is a tough one to answer. I have the information on intramuscular shots. Wanted to know about alternate injection sites and how often should we be rotating sites to minimize problems with absorption. Well, you should always be rotating sites, whether now intramuscular sites or subcutaneous sites. Both should be rotated, and you should rotate it as much as you can. For the subcutaneous injections, the best site is the butt. It's interesting that the ADA doesn't like to publish pictures showing the butt. They advocate the side of the leg, which is the worst place you could use. In fact, you absolutely should not use it. You should use the butt, and it's a great place for rotating sites. Will a non-diabetic fraternal twin of a type 1 diabetic suffer from growing disorders on a low-carb diet, food disorders, or other anxiety problems? It depends how you handle it. I always recommend that the whole family be on the low-carb diet, not just the diabetic child. And if you have a fraternal twin who has very high likelihood of eventually becoming a type 1, the whole family should be on the low-carb diet. That avoids the psychological problems, and the low carb does not cause growing disorders. It's the high blood sugars that cause growth impairment. And if this other child over the years gets slightly elevated blood sugars, a little higher each year, thanks in part to the high carbohydrate diet, then that kid will not attain his theoretical growth curve. So I say the whole family should be on a low-carb diet. How does a patient know when a pump or a continuous glucose monitor might benefit their situation? I suggest you read the book, Diabetes Solution, but also pumps are not going to benefit anybody. The continuous glucose monitor, I recommend for anyone who lives alone, has no one else in their bed, and for kids. And I recommend that the parents use the follower function on their digital phones, telephones, to hear any alarm that is generated by the child sensor. And I also recommend that parents check the kid's blood sugar directly before they go to sleep. But my main worry is when you're sleeping. Now, there may be other situations, like if you're doing a hazardous job and working all day and find it hard to stop doing that job, a continuous glucose monitor might be a good warning system. And I'm sure there may be other situations where continuous glucose monitors have value, but the most important time is when you're sleeping. Well, thanks for listening. Our next teleseminar will be on Wednesday, January 31st. In the meanwhile, have a happy New Year, happy holidays, and a healthy New Year.